And so here's, I've been asked a big subject, azoospermia. And you'll see in the rest of the presentations, there are many, many sub-subjects of azoospermia. So I'll try to do the best I can just to hit some interesting things, though I can't hit everything. This first slide I'm showing you is interesting. It goes back to 1977, when before IVF, and we were just interested in seeing whether a histology, a testicle biopsy, could correlate well with the actual sperm count in the ejaculate. And you can see there's a very good correlation, extremely good, p less than 0.01. But if you look carefully also, you'll see that when the sperm count was 0, we did find in those patients a very small number of mature spermatids and the testicle histology. We didn't make anything about that until ICSI came along, when Paul Leroy and I and Andre van Sturtigum and Peter Nagy all collaborated in Belgium in 1993, because once there was such a thing as ICSI, suddenly this purely academic histologic study we did in 1977 opened up the door to how we can treat azoospermia. So this is the hospital I work at, St. Luke's, and I've really invited all my Egyptian friends to please come and visit us after this awful COVID thing is over, and it will be eventually over. And I can't wait to visit them, because there's something powerful about direct interpersonal communication. We're the bridge. I believe doctors are the bridge across what otherwise can be difficult political barriers and antagonisms that really shouldn't exist. And so we are all a bridge, and we love being that bridge. Now, this is just a nostalgic picture of Paul Devroy and me with the very first Tessa babies born in Brussels. This was in 1993. And it was hard to believe a year before that we'd be able to do this. But there it is, testicular sperm. Now you take it for granted, but then it was like a miracle. So my outline of my talks is, I'll limit it first to the basics of spermatogenesis and some clinical take-home messages that may be startling on spermatogenesis. Second, I'll talk about the surgery, vasoptimostomy for obstructive azoospermia. Then I'm going to talk about the sperm retrieval techniques with ICSI for azoospermia, both obstructive and non-obstructive. Now, the Y chromosome is a huge, fascinating subject, and that's just going to have to be a different talk at a different time. Maybe it's my way of manipulating the Egyptian Fertility Society into inviting me again, because I will accept any invitation. I'm so enamored and so much in love with Egypt. Now, this is just your classic slide of normal spermatogenesis. But if you take a look at it, you can see that the rim right next to the outer portion of the seminiferous tubule, the basement membrane, is composed of dark spermatogonia and pale spermatogonia. You can see that easily. The dark spermatogonia have the spermatogonial stem cells, which is extremely important. The pale spermatogonia are the ones that divide rapidly and form progenitor cells, and really are responsible for the huge number of sperm that are being created. And you can see pachytene spermatocytes and then spermatids. You don't see tails. Don't expect to see tails in most histology, because the tail is thin and the head is thick relatively. And so if you don't see a tail, it doesn't mean anything. When you do Tessa, you will see a tail. But pay attention to those dark spermatogonia by the basement membrane and the pale spermatogonia. And this is just a diagram so you understand the 6 stages of spermatogenesis in the human, and you base that on the spermatid maturation on the top. And there's always that cellular association. And that cellular association is very, very important, where you see you go from dark type A to pale type A, and right around stage 4 or 5 is where the spermatogonia is sensitive to retinoic acid, upregulates the gene STRO8, and enters meiosis. So this anatomic structure is extremely important. So first, spermatogenic stem cells should be the most interesting to everyone. These stem cells stay in the basement membrane and they renew themselves very, very slowly. They do not divide very rapidly at all. Now, this slow self-renewal is important for all stem cells in the body, really, to limit the number of mutations over time, because mutations only occur with mitosis. So stem cells divide really slowly. But they make progenitor spermatogonia, which would be the pale type A spermatogonia, and they really multiply at a very fast rate, but they cannot self-renew. So progenitor spermatogonia eventually are committed to making differentiated spermatogonia. Now, they divide at different rates, as I said. The dark type A proliferate very, very slow, and we don't have any specific stain for spermatogonial stem cells, and I can explain to that in a whole nother lecture about the transcriptome of the testis histologies that we've done. But for right now, all you have to know is we may not see them, but we know the spermatogonial stem cells are a colony within the dark spermatogonia. Now, the pale type A and type B are progenitors, and they divide at an extremely fast rate. And these pale spermatogonia, which you saw in that first slide, are committed, despite initial self-replication, to only making differentiated spermatozoa. So here again, a normal prepubertal boy's testis has these spermatogonia, even though he doesn't have FSH or LH yet. But after radiation or chemotherapy, the pale and rapidly dividing spermatogonia are what's depleted. They're gone. If there's any recovery of spermatogenesis, which will certainly occur in 35% of these cases, we know it'll take several years. Well, why in the world is that? That's because the recovery of spermatogenesis after cancer treatment is from the slowly dividing dark spermatogonia pool, which contains the spermatogonial stem cells, the SSCs. Now, what about when you discontinue testosterone? That recovery is usually less than 6 months because the pale spermatogonia have not been depleted. So it just takes the usual 84 days that I told you about for spermatogenesis to recur. Now, the SSCs can produce spermatogenesis and restore fertility if transplanted into the Reedy testes. I'll show you a great slide of that in a second. But there should be no cancer cells in the testes of a prepubertal boy with leukemia after his initial remission. The cancer cells are still there in the bone marrow, but not in the testes. The more sturdy spermatogonial stem cells, which divide very slowly, survive that initial chemotherapy and can be frozen before the more extensive later bone marrow transplant. So then they can be thawed later on. The boy's cured, he's a man, and we can inject into the Reedy testes. See, you can see the SSC survive the initial chemotherapy, but the cancer cells do not. Now take a look at this video. We're doing this now. This is an ultrasound-guided needle injection of the Reedy testes. Now, every anatomy textbook I've ever seen, every atlas has the anatomy of the Reedy wrong. It's really a linear collecting duct in the center of the testes. It's not this funny river delta near the vasa efferentia. It is really looking like this in all primates, not in the mouse or on the usual experimental animals. Now look at as we inject these SSCs. This is interesting, but not as fascinating as what you're going to see now. It will then colonize every seminiferous tubule. So the seminiferous tubules, just by that injection of the Reedy testes, will colonize every aspect of the seminiferous tubules of the testes and resume spermatogenesis. So it is not until the spermatocyte stage that meiosis begins, and that's when homologous chromosomes line up. And on histology, all you really see are the condensing chromatin of these homologous chromosomes, and those are the pachytene spermatocytes. They begin to split in meiosis 1, but are still held together by the centromere. So we have a 4-end situation forming pachytene spermatocytes. Like spermatocytes then separate from each other, resulting very briefly in secondary spermatocytes. You won't see the secondary spermatocytes on histology because it's so fast. You just don't see them. You see the pachytene spermatocytes in this stage of partial maturation arrest, and you see an occasional condensed spermatid. So what about hormonal regulation of spermatogenesis? Well, We know the pulsatile GnRH secretion, just like in the female, from the hypothalamus, travels directly to the anterior lobe of the pituitary gland. And it's very permissive. It doesn't regulate or control FSH or LH secretion whatsoever. It just allows FSH and LH secretion to be controlled by hormones that are coming from the testes or the ovary in a female. So with FSH only, and you had no LH, the testis does produce sperm, but a very, very tiny amount. We call that the fertile eunuch. That's the man who has a congenital defect where he makes no LH, he has FSH only, and he will have sperm even though he's a eunuch, but it's very, very poor quality. So LH is required for both quality and quantity of sperm. However, FSH is still necessary for at least initiating the completion of spermatogenesis. We gather that from Kallmann syndrome patients. So spermatogenesis beyond spermatogonia stage does not ensue until puberty, and it really requires both FSH and LH. Now, I'm sorry for the misprint there. So this azoospermia syndrome of Kallmann's is caused by the lack of GnRH, which results in no FSH or LH whatsoever. So studies done a long time ago by Sharon showed that you can give HCG for 3 months or full year as long as you want. And you initially think you're getting normal spermatogenesis, but it's only up to the Pachytene spermatocyte. It's maturation arrest. You still need to add FSH in order to initiate that completion of spermatogenesis. However, after that initiation of the completion of spermatogenesis by FSH, all you need is FSH alone for the rest of the patient's life to maintain spermatogenesis. So it's interesting and complicated. This is maturation arrest with HCG only, and this is maturation arrest with HCG only. And if you add FSH, the meiosis is completed and you have normal formation of sperm. So now what about obstructive azoospermia? I prefer an anastomosis. This is an anastomosis of the vas. And before we published this in 1975, everybody thought that vasectomies were just irreversible. But now we know it's just a matter of an accurate anastomosis. However, nowadays, urologists who are doing vasectomies, and there probably aren't many being done in Egypt, but they're being done all over the world, and they seal the vas really tightly. And there's continual secretion of fluid from the testes and the epididymis, and so that creates a pressure buildup, and that pressure buildup results in secondary blockages and blowouts in the epididymis. So nowadays, if you want to reverse a vasectomy, you really have to do a vasoptimostomy. So, but of course, epididymal obstruction also occurs from a variety of diseases. I think we have the largest collection of vasoptimostomies for smallpox epididymitis in the world. And most of them came from the Middle East, but they came to St. Louis. And these are survivors of smallpox, all have epididymal obstruction. So this is the dilated epididymis that you see. And the question is, where is the normal sperm? So when we used to section the epididymis, you could see that there's no sperm at some level. There's nothing getting into the epididymal tubule. But if you go more proximally, again, eventually you get beyond the blowouts and the perforations, and you get to normal spermatogenesis, normal sperm. Now these sperm are old, and so they're old, and they're not going to be motile until they start traveling once again through the epididymis and the vas into the ejaculate. So here are a bunch of pictures I'll show you of specific tubule vasoepididymostomy. This should be highly successful. You're very, very unlikely to have a failure with this. Inner canal of the vas being perfectly sutured, and there's a vasogram afterwards to show you that we really have, it really is a beautiful specific connection. We do end to side now, and I'll go quickly through these so I can get to the other subjects. And MESA is part of that. We retrieve the sperm to find out where the blockage is. And then we do a perfect 2-layer anastomosis. You can see the outer muscularis is first sutured. And then at 6 o'clock, we put in the mucosal sutures. And there's the second mucosal suture. And we can even do this for vasa efferentia blockage. There you can see the opened vasa efferentia with sperm pouring out of it. And we'll anastomose that to the vas in the same way we did the epididymal tubule. And there can be a huge area of missing vas, and you can always free up the vas a long distance if you extend the incision into the groin. And we showed this a long time ago that strikingly, the months to conception was like a life table curve, and the results and the success was not based on the male, because those were almost always successful surgically, simply based on the age of the female. And it fit the original curve of recovery of fertility after contraception in nulla gravida patients that was originally done by Vesey et al. And so not every woman is fertile, but there is a massive age-related decline. So let's talk about, in some of the time we have left, sperm retrieval with ICSI. We do it microsurgically, but under local anesthesia. I think it's ridiculous to put a patient to sleep to do TESA and MESA. All you have to do is anesthetize the cord and then anesthetize the anterior scrotal skin, and they can watch their procedure actually on the TV monitor. And then they just get up and walk away. I mean, they don't go to a recovery room. They just get up and walk and go back home or go to the hotel if they're from out of town. So for obstructive azoospermia, we can do a good anastomosis, but also if you don't want to do that, you can do a sperm retrieval and it works well, but watch out. So you all know that in the distal epididymis, we normally have motile sperm, but in the proximal epididymis, there's no motility because it hasn't matured via transport through the epididymis yet. But that's only in non-azoospermia cases. When you have blockage, the sperm that are more distal are the oldest sperm. They're the most senescent. They look terrible. By the way, you'll note that this picture I drew of the Reedy testes is totally wrong. I mean, the Reedy testes is more of a linear thing going right down the center. So the idea of the anatomy of the Reedy testes in humans has been poorly displayed, but the rest of this is accurate. Now, if you look at the sperm in the distal epididymis, you see a huge amount of sperm DNA fragmentation under electron microscopy, and that's only because these sperm have died of old age. They're the oldest sperm. If you go more proximally, where initially we thought we had the least mature sperm, that's where we find completely normal sperm with good motility. Now, they still don't fertilize well without ICSI, but at least you can see they're motile and they're viable sperm. And we originally studied this a long time ago, and 1994, and with in vitro fertilization with conventional methods and MESA sperm, we only had a 4.5% delivery rate and a 19% transfer rate. But once we introduced ICSI with MESA in Belgium in 1994, suddenly we had a 94% transfer rate and a 36% delivery rate. Of course, pregnancy rates, delivery rates are even higher now because IVF has gotten better. But nonetheless, this shows the dramatic difference that ICSI has made, even with viable sperm. But if you try to do ICSI with a distal epididymal sperm that have DNA fragmentation, you're not going to get good results because those sperm are dead. In fact, I hate to talk about DNA sperm fragmentation because it implies that's a phenomenon other than just senescence. All that fragmentation means is those sperm have died of old age and they're just not viable anymore. And so again, to show you that we were kind of shocked when we found the only thing that affected pregnancy rate with MESA and ICSI was the age of the wife. Now obviously that's obvious to everyone. In 1997, we were shocked to see that. So what about non-obstructive azoospermia? We began to do that also in 1993 with microsurgery. And we began it long before the Cornell enthusiasm for it, and we still do it differently than the Cornell method, and we prefer this method that we use, and I'll explain to you why. This is just, I'm putting back up that slide of our original histology study that was, that goes back to really 1977, when we were just academically interested in whether we could compare the quantitative histology, which no one was doing in those days, to the actual sperm count. And that's when we realized that there are some sperm still in the testes that don't get into the ejaculate and non-obstructive azoospermia. We think they're making no sperm, they're making a tiny amount of sperm, but not enough sperm to spill over into the ejaculate. So if you just look at a histology, it's a classic histology slide showing Sertoli cell only in the upper left and completely normal spermatogenesis in the lower left. And in the upper right, you also see Sertoli cell only. So non-obstructive azoospermia and TESA is not a matter of trying to find immature sperm. You will not be able to get success with immature sperm, which are called round spermatids, because there are always mature spermatids in the human if there are round spermatids. So it's not a matter of trying to get immature sperm. It's just trying to find the occasional sperm quantitatively that are still located in the testes, but not in sufficient quantity to spill over into the ejaculate. And so our approach to microsurgery is just to do no harm, not to dig around in the testicle and destroy the blood supply, but to sample every anatomic lobule along the surface. Because if there's any spermatogenic stem cells, you will find sperm in the periphery where you don't have to do any damage. And you certainly saw that in the ultrasound that I showed you earlier in this lecture. If there's any spermatogenic cells in any anatomic lobule, they will find their way to the periphery. So there are degrees of azoospermia with completely normal spermatogenesis. You have all the tubules have sperm, and there's no azoospermia. But you can have non-obstructive azoospermia with a diminished amount of sperm production, and you can have non-obstructive azoospermia with a severely diminished amount of sperm production. So it's easy to get sperm in those cases on the left, but it's hard on the right. And for that, you have to sample every anatomic novule. Now, digging around is not successful, and I'll show you why, and it's dangerous. So here again is an appearance of a Sertoli cell only case. I mean, that you can see there are no spermatogonia along the sides, but you see these prominent nuclei. These prominent nuclei have a prominent nucleoli, and the Sertoli cell itself is just an amoeba. It's an amoeboid-like cell. So when people were doing tests in the early days, they thought they were injecting round spermatid, but all they were doing was injecting Sertoli cell nuclei. So this is maturation arrest. But in 60% of cases of maturation arrest, you can see at 12 o'clock or at 11:30 position, there are some condensed mature spermatids to be found. So whether it's Sertoli cell only or maturation arrest, it's the same issue. You're not looking for some kind of immature version of a sperm that hasn't developed yet. What you're doing is looking for those small, tiny amount of sperm that are not being produced in a quantitatively sufficient amount to spill over into the ejaculate. This is another example, incomplete maturation arrest. This is how we do the laboratory dissection. And you can see on this pachytene spermatocytes, but there's an occasional sperm. You might have to look for 2 or 3 or 4 hours to find a few sperm because it's surrounded mostly. There you can see is a Sertoli cell nucleus with a prominent nucleolus, but there you can see pachytene spermatocytes. And here again, you see Sertoli cell nuclei, you can see pachytene spermatocytes, but you also see sperm. So my message here is do no harm, and I'll show you how you can do harm. We saw a 37-year-old physician with a 33-year-old wife who had a preoperative testosterone of 371. Then he underwent a bilateral microdissection. No sperm was found, but he noted afterwards increasing fatigue, muscle weakness, and surgery. And testosterone we saw was only 84 with an LH of 50 and an FSH of 75. He was essentially castrated by his procedure. And this is what his reattempted TESA looked like. All of his tubules were fibrotic because when you microdissect, you cannot help destroying blood supply. So what we recommend is, and you cannot tell, you can see thick and thin tubules. We really studied this carefully, and neither one of those is going to be an indication of whether there's spermatogenesis or not. Because look at this, you can see at 400x, SCO on the bottom with no spermatogenesis, and you can see on top tubules with normal spermatogenesis, and they're the same size. So the size of the tubule is only influenced by Sertoli cells and not influenced by the spermatogenesis. So we believe in spermatogonial stem cell approach to TESA because we know that if there are any stem cells anywhere along that basement membrane, that are spermatogonial, there will be some sperm coming to the periphery. So we sample all anatomic globules on the periphery and don't invade the blood supply. Here's a case of incomplete maturation arrest, and it is true that these tubules look fuller. They definitely look fuller. And you can see that they look full. But with Sertoli cell only, it is absolutely true that they look thinner. But there was sperm here that wasn't related to tubules that looked thicker, because the thicker tubule was just where it was making a turn in the periphery. Look at how yellow this all looks. It looks yellow because those are the Leydig cells. It's like a corpus luteum. This is the corpus luteum of the male, the Leydig cells. So you can see the prominent Leydig cell hypertrophy in cases of Sertoli cell only. Then we stop every bleeder microsurgically so that we don't have intratesticular pressure buildup. We close it with 9-O-nylon interrupted sutures. Now this is the round spermatid controversy. This electron microscopy shows you what Bob Edwards always taught us in those early days, and that is that the round spermatid has a prominent acrosomal vesicle that literally glows on phase contrast. And it loses that acrosomal vesicle and it begins to form a tail. So here's the early round spermatid with an acrosomal vesicle. And you can see that it was confused with Sertoli cells nuclei with prominent nucleoli, but that's not what it was. So if you look under phase contrast, you can see the actual round spermatids, but whenever you see round spermatids with that acrosomal vesicle, you'll always see the subsequent stages of spermatids. So how do you really know? Is there any test for telling whether you're going to find sperm or not? No, because there's hundreds of millions of sperm being made every day in the normal testes. And when we're doing TESTA, we're just looking, we'd be happy to find 10 to 20 sperm. So far, we don't have any adequate way, like with FSH level or inhibin levels, of predicting whether we're going to have successful TESTA. Always be prepared to vitrify the oocytes, because you want to have the wife's eggs ready and mature for injection at the time of the TESTA, because what if you only find 10 or 20 sperm? You want to have her eggs ready. On the other hand, you don't want to waste those eggs. And so be prepared always to freeze the eggs in the 40% of cases where you don't have success. Now, I'll just give you an example of Klinefelters, and I only have a few more minutes because they're our most successful case. They're small little testes, and all you see, you see predominant yellow Leydig cells, and there are only occasional little bits of a tubule you see. And look at that, it's just like all yellow. And you think there's no chance. And we close it up microsurgically so we do no damage. And this is what most of the testes looks like. But in 80% of the cases, you're going to find an occasional tubule with normal spermatogenesis. Once again, you are not looking for immature pre-sperm, so to speak. You're looking for that tiny area where there is a tiny amount of spermatogenesis, quantitatively not great enough to spill over into the ejaculate. So this particular case I'm showing you had healthy twins delivered, and here's another XXY, and I'd like to say the XXY Klinefelter's patients are completely normal otherwise. They're absolutely, this idea that they're retarded, less intelligent, is just an old myth that just isn't true anymore. We see lots of them. Maybe 15% of our Azoospermia cases are Klinefelters. Again, you see it looks like there's no hope in this case, and you keep looking around, there's Sertoli cell only, and there is just fibrosis. And then if you keep on looking, you're going to find a few tubules with normal spermatogenesis. Close it up carefully. You see with our technique under local, he's just fine the next day. He has no pain, and healthy twins and 6 more frozen. Now, Exoturners is also interesting. Turner's mosaic men, you can see how short he is compared to his wife, but these guys are otherwise normal except for Azoospermia. They look just like the XXY. And I can go into this in more detail, the interesting aspect of this when I talk about the Y chromosome, because this is what you'd expect. You would really expect to find them to be normal. And there you can see all the Sertoli cell only, a sea of corpora albicans, and then normal spermatogenesis. And so again, we were able to close it up carefully so that we see no damage, and he's making normal testosterone, healthy twins and 8 frozen blastocysts. And what are the results of these with varying degrees of azoospermia or even severe oligospermia? Well, we find pregnancy success is not related to this quantitative defect in spermatogenesis. Whether the sperm count was less than 2 million or greater than 20 million or donor sperm, we did this a long time ago. We found there was just no difference in pregnancy rates or delivery rates. The pregnancy rate and delivery rate is absolutely not related to the sperm. It's really only related to the age of the wife. So that's, and also the ovarian reserve, because you certainly have more of a chance of having at least one viable egg if there are more eggs in ovarian reserve, but they are separate phenomena. So what about the future of testing? I've only got a minute or two left in what they allotted me. In the future, we retrieve tested tissue from prepubertal male cancer patients, culture the spermatogonial stem cells into multiple passages to eliminate cancer cells, or at least retrieve the testis tissue after the initial rounds of chemo, preserving the SSCs but killing the cancer cells, and then transfer these pure stem cells back to the testis. That's one of the great things in the future for TESA. And I show this slide that kind of mesmerizes me, but I've already shown you that. So next, I don't have time, but I'm going to tell you in another lecture that we're working on this now in humans. We certainly can do it in mice very successfully with a collaboration with Dr. Hayashi in Kyushu, Japan. And we can actually take a skin biopsy, convert them into stem cells, convert those iPS stem cells into PGCs, convert those PGCs into normal oocytes and normal sperm, but you need fetal somatic gonadal tissue to do that. And now we know how to do that with simple growth factors. So right now we're already making human PGCs from skin biopsies in azoospermic men. And now the next thing we have to do is figure out how to culture them in somatic fetal testis cells. So I think my time is up now.